I'm going to talk about psychological impact of diabetes. Diabetes has many psychological consequences and comorbidities like diabetes denial, dementia, depression, and diabulimia. And let me start with diabetes denial. And denial is that voice inside repeating, not me. Most people go through denial when they are first diagnosed with diabetes. They say, I don't believe it. There should be some mistake. Denial is the psychological state in which one is exempt from reality. Diabetes in denial is either an individual who has diabetes but is in denial about it, ignoring his disease by not controlling it, does not test his blood glucose regularly, eats whatever he wants, and is not following any strict diet, and does not see the doctor when he should. Or another case, someone who may be a diabetic, but who hasn't or doesn't want to get tested. He frequently goes to the bathroom. So he has diabetes symptoms and he's having thirst, he's having polyuria, polydipsia, and usually fatigued. He's experiencing numbness and tingling in his legs, hands, or feet. So why denial? Denial sometimes serves a purpose. It's a way of coping from bad news. It can keep the patient from getting overwhelmed and depressed. It lets the patient accept news little by little when they are ready. My message to the patient, but denying that you are diabetic, is serious. It lets you avoid self-care. It shields you from the fact that diabetes is a long life chronic illness, which if left untreated can result in complications. Denial also lets your family and friends pretend that you're not diabetic and nothing is wrong. The hidden danger of diabetes denial: these patients are not testing, they are ignoring the meal plan, they are forgetting the feet care. How to avoid denial? Write down your diabetes care plan and your health care goals and understand why each item in your plan is important, and accept it will take time to reach your diabetes goals. And if you have trouble with your food plan, talk to a registered dietitian and tell your family and your friends how they can help you and to encourage you. They might also want to adopt some of your healthy habits. And let me now talk about dementia. And senility is not the normal aging. Senility means dementia, and dementia is the clinical syndrome characterized by insidious onset and slow progression of cognitive impairment. This cognitive impairment at least impairs two areas of cognitive function. For example, memory loss, impaired verbal fluency, and impaired executive functions. And this is the American Psychiatric Association definition of dementia. They have established two generally accepted criteria for the diagnosis of dementia. The first criteria is erosion of recent and remote memory, and the second criteria is impairment of one or more of the following cognitive functions, like language, misuse of words, inability to remember or use words correctly, and motor activity impairment, unable to perform motor activities, even when the physical ability is intact. Recognition, unable to recognize objects. Executive functions, unable to plan, organize. Symptoms often develop gradually, having a progressive deterioration of function. This is Dr. Alois Alzheimer, and he was the first one to describe Alzheimer. He examined the brain of a 55-year-old woman. She had died after a rapid downhill course of premature senility or dementia. Examination of the brain showed a mass of distorted, twisted protein fragments in place of normal brain cells. Later, it became known as Alzheimer's disease. Diabetes doubles the risk for dementia. And in Fremantle study in Australia, there was comparison between the Fremantle diabetic patients and the Australian survey, and dementia was increased up to 3 times in patients with diabetes above the age of 80. The risk factors for dementia, one of them is depression. Depression in diabetic patient is another risk factor for dementia, hospitalization, and even death. Diabetes and depression are independent risk factors for vascular and Alzheimer dementia, and effective treatment of depression and diabetes may be one of the most powerful interventions for decreasing the prevalence of dementia. This is a prospective cohort study of almost 10,000 women aged between 65 and 99 years. And women with diabetes experienced an accelerated cognitive decline. Another trial on more than 6,000 subjects above the age of 55. They were dementia-free at the baseline, and they were followed for more than 2 years, and patients on insulin were at higher risk for dementia. These are the possible pathophysiological mechanisms linking diabetes with changes in the brain, and diabetes will lead to many pathologies like macrovascular disease, cerebral infarcts, microvascular disease, ischemia, hyperglycemia, advanced glycated end products, oxidative stresses, repeated hypoglycemia, which is an important risk factor for dementia, hyperinsulinemia, and insulin resistance. These pathophysiological defects in diabetes, together with genetic predisposition and some comorbid medications, will lead to vascular pathology, aging pathology, and Alzheimer pathology, and eventually lead to dementia. This is a study showing the risk of Alzheimer's disease in elderly with and without metabolic syndrome, and in females with metabolic syndrome, there was increased incidence of dementia compared to those females without metabolic syndrome, but this association was not seen in males with metabolic syndrome or without metabolic syndrome. Let me now discuss an important topic, diabetes and depression. And depression is a common and serious disease, often leading to suicide, and suicide rate is double the rate of homicide in a country like USA. Depression will be the second leading cause of disability worldwide and #1 cause of disability in developing countries. These are facts about depression. The percentage of population that will experience this depression at least once in their lifetime, 10% of males and 20% of females. Odds and prevalence of depression was doubled in diabetics compared to controls. And there is association between depression and diabetes complications, whether all complications or specific complications in type 1, in type 2, retinopathy, neuropathy, nephropathy, and macrovascular complications. All these complications are increased in the presence of depression. But does the reverse happens or not? Does depression increase the risk of diabetes or not? This is a bidirectional relationship. Diabetes can lead to depression, and depression can lead to diabetes. And in depressed persons, the risk of developing diabetes has been shown to be twice that of non-depressed persons. So depression doubles the risk of type 2 diabetes, and this was shown in different trials. And coronary heart disease occurs in diabetes with depression. Yes, it's increased in diabetes with depression. It occurs in 39% of diabetics with depression. What's the effect of depression treatment on hemoglobin A1C? On hemoglobin A1C and depression treatment, there was reduction of hemoglobin A1C up to 0.9% hemoglobin A1C reduction. What are the symptoms of depression? And they include the persistently sad, anxious, or empty mood, feeling of hopelessness, pessimism, feeling of guilt, worthlessness, helplessness, loss of interest or pleasure in hobbies or activities that enjoyed previously, including sex, decreased energy, fatigue, being slowed down, difficulty in concentration, remembering, insomnia, early awakening, or oversleeping. Restlessness, irritability, appetite or weight changes. Appetite, either increased appetite or anorexia. Thoughts of death or suicide or suicidal attempts. If 5 or more of these symptoms are present every day for at least 2 weeks, interfering with routine daily activities such as work, self-care, and childcare or social life, we should seek an evaluation for depression. A study was done on 5 groups of diabetics, those on diet and exercise alone, and those on oral medications, and those on oral medications and 1 injection of insulin, those on 2 injections of insulin daily, and those with 3 or more insulin injections per day. And the study showed a strong correlation between depressive symptoms and glycemic control in patients with complex insulin regime. How to optimize management of diabetes and depression? Initial intervention include evaluation of depression as a contributor to the development of type 2 diabetes, or to evaluate depression as a contributor to poor metabolic syndrome in any type of diabetes. So either depression will lead to development of type 2 diabetes or will lead to bad control of any type of diabetes. Then we treat clinically significant depression, and we may maintain a prescription for relapsing depression. What is the role of diabetologists in patient education in patients with depression? These are some advices to our patients: to lift your spirit, join a support group, share your thoughts and feelings with others who also may have the disease, learn new skills to cope better. Keep a journal of good things in life and blessings. Plan an enjoyable day. Do something you love. Go shopping, work in a garden, go for a walk at the park, or have lunch with friends, or see a comic movie. What about exercise? Exercise, just moving, can work wonders for the way you feel. Talk to family or friends. Sharing your feelings can help release built up emotions and get their support for needed changes. Volunteer helping. Volunteer helps us feel good about ourselves, that we are making a difference in someone else's life. And let me finish my presentation with diabulimia. And diabulimia is a serious condition when type 1 diabetes are not taking insulin in order to lose weight. Diabulimia is a term recently cropped. Most people who experience diabulimia are stuck between two fears: taking increasing doses of insulin, which leads to weight gain, and the destructive behavior causing their body in the long term. Diabulimia is recognized as a psychological and medical condition. It is most common in young diabetic women, and diabulimia is a practice of lowering or completely omitting insulin as a way of losing weight. One expert has studied the phenomenon of diabulimia, estimated that there is 450,000 type 1 diabetic women in the United States. They are skipping doses or decreasing their insulin to lose weight, risking a coma and an early death. It is a severe diabetic complication, may happen earlier due to diabulimia, like comas and chronic complications. These patients are saying complications are inevitable, so they can risk omitting insulin or decreasing the dose of insulin in order to lose weight. Women with type 1 diabetes are twice as likely to develop an eating disorder than those without type 1 diabetes, and the risk of eating disorder is coupled with type 1 diabetes and significant. Let me finish my presentation with this statement. Do diabetic patients need more psychological support? And this remains to be elucidated. Thank you.